right. Good morning.
Good morning.
How are you?
All right, and yourself?
I'm well. I'm well. Hanging in there.
Good,
Hanging in
good.
there. Whirlwind annual meeting in Columbus. Lots of things moving and shaking. I was just tickled and chuckling the entire time, but it was good. It was good. How you been? How's your weather?
It was really, really nice. Then it got rainy and cold again.
I know. Same thing. Same thing. It was like, ugh. Turn it back on and stop playing with us. How was your week? Your week? How was your work week?
It was, how it's this is just a lot.
A
It was a
lot.
week, yeah.
Oh my goodness. All right, all right. Well, let's see. Good morning, Natasha. Good morning. Good morning. Happy Saturday. Happy Saturday.
Good morning.
Yes, yes. All right. Well, let's get this started. How did I pin my own thing? See, me and these buttons. I promise you, are going to be the death of me. Welcome, everybody, to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, the weather, and how these weeks be weakened. Certification tips, entrepreneurship, pivots, all of the great things related to the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified, marketable medical coder? Do you? Well, before I introduce my co host, let me share with you information on the 5 steps to become a certified, marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified, marketable medical coder. Learn more at bit.ly/5stepscoder. I think I'm gonna refresh that. I'm gonna keep the music, keep the words. I think I'm gonna refresh some of the pictures. Even though the lady with the pearls, she caught my eye way back when I saw her. I said, "Come on, lady with the pearls, you can fit right on in. I don't care what you're doing. You got on some pearls." So that's how she got it. Little backstory.
All right.
Anyway, if you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. So joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for a long time. In 2014, I left the bedside and started in risk adjustment coding. And during the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how's that going?
It's coming along.
Okay. So you got some new frames.
Well, actually, since they've been so long, I got some colors and variations.
Okay, look, you know me, I pay attention to detail. I said, wait a minute, something new. I like them. I like them. You
Thank
like those
you.
too? All right.
Yeah.
All right. Colors and variations. Here we go. We gonna have to check in every week to see who you gonna turn out to be. Who are you this week? It's like my mom and her Gemini. I be like, Lord, what am I getting this morning? I never know. All right, all right. Well, before we jump in, let me remind you that you can join in and add to the conversation. Don't be shy. Your opinion matters and is welcomed here. So, friends, please use the chat. And if you have a question for us, all we ask is you put a Q first so we know to be looking for it and we won't miss it. So, for those who are just joining us or watching the replay, today we are talking Aetna pays 117.7 million. I feel like, dude, $1 million on a on an MA risk adjustment fraud. Ooh, child, when I tell you, I think everybody's been talking a little bit about this. Everybody. But first, let's check into our church announcements, shall we? See, I want to say like your shirt. Can we kick it? Yes, we can. There we go. Uh-oh, right on the same cue right there. Hey. Hey, my nail polish might a little green here.
Oh,
Hey. 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 All right. Well, actually, I really don't have any church announcements today. I ain't had time to go research like I was supposed to, so I wasn't on my job. Except that, remember, we will not have a live broadcast next Saturday or the following Saturday.
Yeah.
But I'll put something out there together so that you could join and watch. But we won't have a live broadcast. Okay? Mr. Jesse, do you have any church announcements for the people today?
Actually, no, because I don't have a date, but I'm going to be announcing a course soon. I don't even have a date ready.
He looked out there like, all right. Well, that was a real quick church announcement session. Real quick. All right. Well, let me get rid of this. All right. Well, let the tea spilling begin. Good morning, and welcome back to the Saturday Morning Tea, where we serve up the real talk our profession needs. I'm Clarice Warner, the girl with the pearls, with my partner in success, the coding nurse. And if you're new here, welcome. We meet every Saturday morning unless we're not, to demystify medical coding, billing, and everything that keeps healthcare revenue flowing, and talk about the things in healthcare that actually matter for your career, your compliance, and your paycheck. And to my returning friends, thank you for being here. So pull up a chair, wrap your hands around that cup, like me, or whatever type of cup you use, no judgment here, and get comfortable. Because this morning, we are talking about $117.7 million. Yes, that's not a rumor. That's not a projection. That is the price tag that Aetna, one of the largest health insurers in the United States, has agreed to pay the federal government to resolve allegations under the False Claims Act. And the settlement was announced just this week on March 11th. Now, I know some of you just did a double take, $117 million. Yes. And when you understand why and what role medical coding plays at the very center of this, I need you to understand something very clearly. This story is about us, about what we do, and about why the work of health information professionals is not clerical. It is consequential. It is financial. It is legal. And it matters every single day. So stay with us through this morning. I'm going to walk you through exactly what happened, what it means for you professionally. And because I'm always going to leave you better than I found you, I'm going to give you 3 powerful career pivots and a clear path forward. Some of these may sound familiar. We've talked about them. And believe it or not, these were on the lips and mouths of a lot of the presenters that we had at our OHIMA annual meeting. Folks are talking about all of these pivots a lot. And the funny thing is, um, I know like last year and the year before, there was a lot of talk about AI and what AI can do and da 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 da. The funny thing is this year, a lot of those claims were kind of walked back. They was sitting a little different this year. Yes, AI is here. Yes, they're making strides. Yes, they're creating and implementing and updating and all of the things for AI to do a lot of the things within the revenue cycle. But all of that um, feeling of these machines about to take over the world, especially our world, that was all walked back. Oh, we need you. We need you to be there for this. We need you to be there for that. We and these this is actually coming from, like AI vendors, the folks who are actually trying to convince your CFOs of the world that this is needed and why it's needed and et cetera, et cetera, et cetera. So it was real interesting. That's why I said I was chuckling a lot. It was real interesting. Um, some of the walk back. And I was like, oh, well, when you were here just last year, that is not what you said. Somebody done tapped somebody on the shoulder and said, chill out. All right. Now, let's remember it could all be so simple. And by the end of this episode, I want you to know exactly how. So let's talk a little bit about um, what's happening here. So, I like to make sure we are all on the same page and we have the same foundation and that we're standing on the same ground. So, before we get into this Aetna case, let's talk about some things because, again, context here matters. And understanding this history behind this issue will make everything that follows click a little easier in place. So, how Medicare Advantage actually works and why coding is central. First of all, we have some acronyms. Folks may or may not know, but if you don't, MA, and I probably say that, or Medicare Advantage. CMS, we should all be familiar with, Centers for Medicare and Medicaid Services. MAO are Medicare Advantage organizations, and HCCs, hierarchical condition categories. So let's start at the very beginning. And Mr. Jesse, you know to pop in as you pop in. Medicare Advantage, or it's also known as Medicare Part C as well, is an alternative to traditional Medicare where beneficiaries choose to enroll in a private health plan rather than receiving their benefits directly from the federal government. Now, here's the piece that connects directly to coding, and this is where I want your full attention. EMS doesn't just pay Medicare Advantage organizations or MAOs a flat fee per member. No, ma'am. No, sir. CMS calculates what it calls a risk adjustment capitation payment, and it's a monthly per person payment that is adjusted up or down based on how sick or healthy the enrolled beneficiaries are expected to be. So the sicker the patient population, the higher the payment. The healthier the population, the lower the payment. And how does CMS determine how sick or healthy each person is? Mhm. Yeah, you probably guessed it. Diagnosis codes. The ICD-10-CM codes that providers uh, that we used based on provider documentation, and that we translate and submit to these payers. So that sets the ground for what's going to happen. Those codes feed into what's called the HCC model. The HCC model groups diagnoses into categories that carry different risk score weights. More complex, more costly conditions carry higher weights. Higher risk scores mean higher capitation payments from CMS. This is why coding accuracy in the Medicare Advantage space is not a technicality. It is the financial foundation of the entire payment system. Every code submitted is essentially a financial statement to the federal government saying, our enrollees have these conditions and they need this level of care. Mhm. Yeah. Now, let me give you, well, let me tell you a little more. So, the government has been scrutinizing MA risk adjustment fraud since at least the early 2010s. Uh huh. a long time ago. CMS introduced mandatory RADV audits, which are risk adjustment data validation audits, in 2012. Since then, the Department of Justice, um, FCA enforcement in the MA space has grown dramatically. Major settlements have included United Health Group, Anthem, Cigna, and others, often in the hundreds of millions. And Aetna now joins that list. And this is not a new issue, but the thing is, enforcement is accelerating. They're opening up the floodgates, and here they come. And they've told you this. Shouldn't be the warning. The shots were fired. They let you know a while back that they were coming and coming with a bang. Now, let me give you a little more historical context because this helps explains why enforcement has ramped up so dramatically. Medicare Advantage has been growing every single year. When the program was formalized under the Medicare Prescription Drug Improvement and Modernization Act of 2003, the MMA 2003, enrollment was modest. Folks were still hanging on to their traditional Medicare. Well, today, more than half of all Medicare beneficiaries, that's over 33 million Americans, are enrolled in a Medicare Advantage plan. And that number is projected to keep climbing. And as the enrolled population grows, so does the dollar amount flowing from CMS to these MAOs. More beneficiaries, higher acuity, higher risk scores, more money. We always talk about follow that dollar. It is a system that was designed to be responsive to patient need, and it works beautifully when the data feeding it is accurate. When it isn't, we end up with the headline we are talking about today. And here's something I want you to understand about the government's posture. CMS has been sharpening its data analytics capabilities for years. The RADV audit program, again, the risk adjustment data validation, has been in place, as I mentioned, since 2012. Well, in 2023, CMS published a final rule that significantly expanded its authority to extrapolate RADV audit findings across an entire plan population, meaning one sample of mismatched codes can now result in recoupment demands that cover hundreds of thousands of beneficiaries. The financial exposure for inaccurate coding is not shrinking, it is compounding every single year. So when I say the government pays over $530 billion per year to Medicare Advantage organizations, I want you to sit with that number. 530 billion dollars annually every single year, based largely on the diagnosis codes that flow from medical records through coders to CMS. That is the scale of the system we operate in. And that is why accuracy in both directions is non-negotiable. So this case, let's break down all of this, what's happening with this one. So let's talk about what the government says Aetna did. Now, I want to be clear, as the Department of Justice itself noted, these are allegations, and there has been no formal determination of liability. The settlement resolves the claims, but the facts that have put us in this situation are instructive for all of us today. The allegations against Aetna actually cover two separate issues, and they are related but distinct. So, for payment year 2015, the government contends that Aetna operated what's called a chart review program. A lot of us have those, right? It's part of compliance. Let's make sure everything is what it should be. Where in this case, it paid diagnosis coders to review medical records, identify all conditions documented, and submit additional diagnosis codes to CMS to obtain additional risk adjustment payments. So, check this out. So you have the coders or the folks in the organization that actually sees the patients. They have their coders. They're doing their job. They're, doing what they're supposed to do based on what they see. They submit the documentation and all the information. Well, they submit the claim to to Aetna, the payer, um, for reimbursement, all the things that normally happen in a revenue cycle. Well, Aetna decides and determines we need our own chart reviewers to validate or make sure or whatever. So then they reach back and say, you need to send us the documentation, da 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 da. This chart review happens. So they have, like I said, they've paid additional diagnosis coders to do all of this review. Mhm. Okay, just sit with that. Now, chart review programs are not inherently improper, not at all. Used correctly, they serve a legitimate purpose, ensuring complete and accurate capture of all conditions that are documented in the medical record and actively managed. So, technically, what they're supposed to do and what it's supposed to look like is be an additional set of eyes to validate what was sent over. So, just in case they may have missed something in on the organization side, we got another set of eyes to kind of make sure that what y'all sent was correct. Really what it was what's supposed to look like and how it's supposed to work. But here's where the government's allegation gets specific and significant. The government contends that when Aetna's chart review added codes, those codes went in and CMS paid more. But when those same chart reviews found that previously submitted codes were not supported by the medical record, again, doing what they're supposed to do, Aetna did not delete or withdraw those codes, which would have required them to reimburse CMS. Somewhere the system failed and failed in a big way. The government's allegation is essentially this: Aetna used the results of its own internal chart review program selectively. Take what helps you get more money. Ignore what tells you you've been overpaid. It's a one-way door, and the government says that that door led directly to the False Claims Act violation. Mhm. So again, chart review is a two-way obligation. So you're capturing additional supported codes, it's only half the job. Deleting or withdrawing codes that the review reveals are not supported is equally required and equally important. And it's a process that only goes one and a process that only goes one direction is not a compliance process. It is a revenue optimization scheme. With that. All right. Next, we got a little acronym coming. BMI, body mass index, and it's a numerical measure of body fat based on height and weight. I'm sure we've all heard about BMI. With all of the weight loss stuff happening across our country and in this world, we didn't heard that term before. So the second allegation covers payment years 2018 through 2023, 5 years. And it involves a very specific diagnosis code, morbid obesity, coded as E66.01 in ICD-10 CM. Morbid obesity is an HCC that carries meaningful risk score weight. That means submitting that code increases what CMS pays the plan for that beneficiary. It represents a more complex, more resource intensive patient. The government contends that Aetna submitted or failed to delete morbid obesity codes for beneficiaries whose body mass index or BMI recordings in the medical record were inconsistent with a clinical diagnosis of morbid obesity. Now, here's why that matters technically. Morbid obesity, also called class 3 obesity, is generally defined as a BMI at or above 40 or a BMI at or above 35 with significant comorbidities, depending on how the treating provider documents the condition. The medical records for individuals diagnosed with morbid obesity will typically include one or more BMI recordings. If those BMI values don't support the diagnosis code should not be in the submission. The government says for years, the BMI was in the record, the morbid obesity code was in the submission, and the two simply didn't match. And Aetna submitted or retained those codes anyway, resulting in inflated risk adjustment payments from CMS. Mr. Jesse, you want
It could all be so simple.
to?
I mean, I continue to be just amazed at how they still continue, knowing that eventually they're going to get caught. Like, this is so easy. And, the problem comes in with it all comes down to policy and enforcement because I mean, morbid obesity is one of the easiest things you could ever code. I mean, either you have a BMI of 40 or more, or you don't.
Or you don't.
Or if it's 35, then the provider you can't pick and choose what comorbidities there are. The provider has to say it.
Mm.
So it's just I just don't understand how in the year of our Lord 2026 this is still going on.
My God,
I I
today.
I really can't. Like when I tell you I have no words, I have none. I started in risk adjustment in 2014, and thank God I started somewhere where they had policy and they enforced it and they trained us.
Mm.
And if it's not there, it's not there.
It's not there. It's not there. So, as a clinical note, a coder reviewing a chart that contains both a physician documented morbid obesity diagnosis and a BMI in, say, the 30 to 34 range faces a documentation conflict. That conflict requires a physician query, not submission of the code and not deletion without inquiry. The provider must resolve that discrepancy. There's a discrepancy there. The doctor has said something, but the numbers say something totally different. What's real? What's happening here?
Oh,
And the provider must resolve that discrepancy. Go ahead.
and the discrepancy needs to be resolved before it leaves that institution because
Say
once
it.
it goes to an outside company, they're not going to query anybody. If it doesn't match, they're going to remove it,
And
period.
it's there, right? Because now you done submitted it and you've submitted a
Hmm.
quote unquote false claim. So this documentation integrity principle is at the heart of both CDI and risk adjustment compliance. FCA, False Claims Act, it's a federal law that imposes liability on persons and companies who defraud governmental programs. Now, I want to explain why these allegations constitute a False Claims Act violation, specifically because this is important context that every health information professional should understand. The False Claims Act, which was passed originally way back in the day during the Civil War in 1863 to combat contractor fraud against the Union Army. It makes it illegal to knowingly submit false or fraudulent claims for government payment. It also applies when an organization knowingly avoids repaying an obligation to the government. So here is the FCA hook in this case. Aetna certified in writing to CMS that the diagnosis data it submitted was accurate and truthful. That certification, combined with the alleged submission of inaccurate codes and the failure to repay CMS when the inaccuracies were identified, is what the government says makes this a False Claims Act violation. You can't certify accuracy while simultaneously knowing that your own internal reviews are flagging unsupported codes. Somebody knows something. Y'all need to check in. Check in real quick. Now, the whistleblower was a coder. Qui tam is a Latin term meaning he who sues for the king as well as for himself, allows a private citizen to file a lawsuit on behalf of the government and share in any recovery. I want to take a moment and talk about something that I think is one of the most powerful pieces of this story. And I want every single coder and health information professional listening right now to hear this clearly. The morbid obesity allegation, the second allegation in this settlement, was not uncovered by a federal audit. It was not discovered by a CMS data analytics suite. It was initiated by a whistleblower lawsuit filed under the False Claims Act key tam provisions. Mhm. We already talked about the word key tam, he who brings the action as well as for them as well as for the king, refers to a legal mechanism where a private individual can file a lawsuit on behalf of the federal government against any person or company they believe has defrauded a federal program. Listen to that. Person or company. If the case succeeds and the government takes it on, that's where the caveat hits, because the government may be like, we don't know, we don't think. But if they take it on, the whistleblower receives a share of the government's recovery. The whistleblower in this case is Mary Millette Thomas. Mary, where are you? Blink 3 times if you're safe. And her title at Aetna? Risk Adjustment Coding Auditor. She was a coder, an auditor, one of us, someone who sat in a role a lot like many of yours, reviewed records, saw a pattern that didn't add up, and took action. As a result of that action and the settlement that followed, she will receive $2,012,500 as her share of the recovery. Now, I'm not telling you that story because I want everybody to go file a lawsuit. No, but you might be thinking it in the back of your head. I did emphasize a couple of things when I talked about key tam, but nevertheless, I'm telling you that story because I want you to understand the weight of what you know, the expertise you carry as a health information professional, the ability to look at a record, understand the codes, recognize when something doesn't align. That knowledge is not just professionally valuable, it is legally significant. The False Claims Act key tam provisions exist precisely because the people closest to the data, the coders, the auditors, the CDI specialists, are often the first to see patterns of fraud. Your professional knowledge is a public health asset, and the system recognizes that. So the False Claims Act also provides anti-retaliation protections for employees who report fraud. If you experience retaliation for raising a legitimate compliance concern, you have a legal recourse, regardless of where it goes in this process. Know your rights. Document your reports. That's why I always say, keep a record of all of the things, all of the things. And know that reporting fraud is not disloyalty. It protects patients, programs, and professionals alike. You drinking.
That's our money.
That's our money. Our money. Okay. So also we know that enforcement is accelerating and not slowing down. So let's talk about what this settlement tells us about the direction of Medicare Advantage compliance enforcement. Because T-sippers, this is not an isolated incident. This is part of a clear and sustained pattern. The Department of Justice Civil Division, the U.S. Attorney's Office for the Eastern District of Pennsylvania, right there in y'all neighborhood, and HHS OIG, the Office of Inspector General for the Department of Health and Human Services, coordinated this investigation together. These agencies are not pulling back from Medicare Advantage enforcement. They're leaning all the way in, grabbing buddies and friends and all of the things. The Assistant Attorney General stated publicly that the government pays over $530 billion a year to care for Americans in Medicare Advantage. Again, that level of investment demands that level of oversight. And the tools available to investigators are getting more sophisticated every year. Yes, artificial intelligence and machine learning are now being used to flag anomalous coding patterns. These are submissions where diagnosis codes consistently appear without supporting clinical indicators, where deletions are consistently absent, and where the same high value HCC codes appear across large populations in patterns that don't match clinical norms. What used to require a whistleblower to surface, a data analytics engine now detect at scale. So your compliance obligations, again, this is bi-directional. So what does this mean for how you approach your daily work? Well, let me be clear and direct about this because this is important. If you work in risk adjustment coding, chart review, CDI, health information compliance, or if you code for organizations who work flows into Medicare Advantage data, here is what this case tells you. First, your obligation is to accuracy, not to revenue, not to code volume, accuracy in both directions. And I know that may be contrary to what's happening in your organization because it's all about production. We talked about this just last week. Production and pushing it out and doing this and more with less. Keep it churning, pushing, pushing, pushing. With minimal to little thought about accuracy. We'll catch that on the back end. Well, in some cases, the back end don't happen because they done start flagging you. They done start looking to say, well, wait a minute, we keep seeing this pattern. What is this? What is this? And while initially they may tap you on the shoulder and be like, sir, ma'am, pay attention here. We telling you, but we need not continue to see this, sir, ma'am. Once they continue to see, it's a different conversation because they ain't gonna talk. Ain't no more talking. We done said what we need to say. I done said my said. Said what I said. But you keep doing it. Okay. Keep on. Keep playing with the church's money if you want to.
There you go.
So you are not just there to find codes that support higher payments. You are equally there to ensure that codes that are not supported by documentation don't get submitted. And that if they have already been submitted, they get flagged, reviewed, and if appropriate, deleted and repaid. So to Mr. Jesse's point, you want to flag everything before it goes out the door. But if you discover that it has gone out the door, then you need to be sending some letters. Hey, ma'am, sir, over here in the Medicare Advantage CMS world, we have identified XYZ. And we know we need to make a repayment of X amount of dollars. Here is the check. And this is what we've done to mitigate that. This is what we're doing. This is our corrective action to make sure that we're catching this going forward. Please don't hit us with a False Claims Act because that little check of $10,000, $5,000 could easily be $117.7 million with extrapolation and fines and penalties and all of the things. Okay. Second, clinical indicators matter. BMI values, lab values, diagnostic findings. These are not decorative details in the medical record. They are clinical evidence. And when they contradict a submitted diagnosis code, that contradiction must be resolved through a physician query, through documentation review, before the code is retained or submitted. Third, if your organization's process only goes one direction, if chart review has a robust workflow for adding codes and no real workflow for deleting them, that is a compliance gap. And now that you know it is a compliance gap, you have a professional obligation to advocate for change. Make sure you document. That's all I'm saying. Make sure you document dates, times, people, and positions. A word on vendors and third-party coders. Now, I want to speak directly for a moment to the coders who are working as contractors or vendors, or you are the vendor, or as remote coders or workers doing chart review or risk adjustment work, because I hear from a lot of you in this community. Aetna's chart review program involved paying outside diagnosis coders to review records and identify conditions. Your work product, wherever you sit, flows into the data pipeline that goes to CMS. If the organization you code for has a pattern of capturing codes without withdrawing unsupported ones, you need to be asking hard questions. If you are the vendor and you are the head CEO person in charge of this particular operation, you need to make sure that you understand how things are flowing within your organization. You need to know that your professional credential, your CPC, your CRC, your CDIP is attached to the work you do and the standards you uphold. Mhm. You need to be concerned with accuracy. We've said it all along. Accuracy. Based on what you got, you can't make it more or less. You got to base it on what you have. Mhm. Now, you earned all these credentials. You might want to try to protect them. They can be taken away. Now, I want to take this one step further because I know many of you are navigating work environments where the pressure to produce, to hit a quota, to code a certain number of records per hour, to keep the revenue pipeline moving is real. I hear you, I see you, and I want to speak directly to that tension. Productivity, oh, and we had a whole case about productivity. We had a whole session, 45 minutes talking about productivity. We'll talk about that another day. But anyway, productivity expectations in this field are not going away. Some of them are off the chain, but again, we'll talk about that later. But here is what I need you to understand: sustainable productivity, the kind that does not eventually cost you your credential, your reputation, or your organization $117 million, is built on accuracy and not on speed alone. A coder who reviews records completely, flags clinical contradictions, and escalates concerns compliantly is not a slow coder. They are a valuable coder. They are the coder who does not become a liability. And in the current enforcement environment, that distinction matters more than ever. So if your productivity standards are structured in a way that makes thorough documentation review generally impossible, that is a compliance conversation worth having with your supervisor or your compliance officer. You are not being difficult. You are trying to help the organization being compliant. And you are also being professional. Mr. Justin,
Yeah,
I see you moving around.
exactly. Because you know what these reports don't really go into is what I think they need to do is I think they need to start naming who these third party companies were, because I would be
Mm,
willing to bet money.
mm-mm,
I would bet everything I have that they were not domestic
mm,
review companies.
mm-mm.
And if you are in the Philippines or India, what do you care? I mean, it's not going to
And
come
what is
back
the
to you.
enforcement there? Right. That's another
There
thing.
is none.
So this is even a bigger conversation for real, for real. I
And
mean, if
and,
we,
and it,
we take
it
a look at
doesn't.
that part.
Right, and it doesn't get to the heart of it, because like that whole productivity thing, like, I mean, the bottom line is you have to produce or they're going to get rid of you. Period. That is just no in between. Like they don't care. They really, really don't. And I can guarantee you the reason why Mary filed that lawsuit is because Mary brought it to somebody's attention and they ignored her. I'm telling you, that's what
And
happened.
that's
I
how
was
it happens. So
Mhm.
these compliance professionals, these senior management, these people in a position and authority to act, don't be ignoring these people when they come and tell you y'all better do y'all due diligence and check and see and validate and document and whatever. Don't be
because the
ignoring the
thing because the
folks.
thing about it, like I mean, well, I just don't know how it even got that far, because even like I don't think well, maybe a lot of people don't know the whole RADV process, especially when it comes to the government. the government will, they don't just take one review and say that's what it is. Like they go through two initial rounds and they go through two secondary rounds. They use four different companies. It's not the same companies that review. They use four separate companies to review.
Because
Then
they want to
based
be
off of
firm in their findings.
hmm so I have just never understood, and I've said this a gazillion times on this podcast. Risk adjustment is some of the easiest coding you could ever do. And they have complicated it so much so now to the point now they have moved from risk adjustment to full code capture. Do you know how hard it is to code full codes and still make productivity? You code in GERD and all kinds of foolishness.
Mm-mm-mm.
Gout in your daggone pinky toe? No.
Not gout in your pinky too, sir.
Because I had just, I mean, I actually just last week I was like, look, I saw a part-time risk adjustment position. They had
Mhm.
flexible hours. I'm like, oh, okay, since I'm moving away from coding, they'll keep my little hands in it. I sent my resume in. The man gonna talk about. He's responded back. Um, the recruiter wants to know if you have full code capture experience. I said yes, and I'm not interested. I'm not. I said I'm not doing full code capture for what you're trying to pay. No,
Not for
mm-mm,
risk adjustment.
no.
Lord, Lord.
Because if you're doing that, that's not risk adjustment. It's not
No,
full code capture is
no,
not risk adjustment.
not at all.
Risk adjustment has approximately 10% of all ICD-10 CM codes risk adjust. So why am I looking at a daggone traumatic fracture and versus a pathologic fracture? Why? Why do I care?
That doesn't sit in the same bucket. That sits outside of that
Mm-mm.
bucket. And to your point, you need to pay appropriately. Whew. All right, y'all. This is my part. This is where we make it personal. Now, I have 5 questions for you, and I really want you to sit with these. Now, whether you're watching live in the comments or you're catching this later, drop your answers, your thoughts, your reactions. Put them in there. This is how we learn together. So, the first question is about that two-way door. If you work in chart review or risk adjustment coding, does your organization, and you don't have to name names, does your organization have a process for deleting or withdrawing unsupported codes that is as robust as its process for adding new ones? Yes, no, or honestly, you don't know. Because that answer tells you something important about your environment. Question number 2, the BMI question. Again, morbid obesity, E66.01, is an HCC. But how many other high weighted HCC diagnoses in your current organization's risk adjustment submissions might have a documentation to code alignment problem? When did you or your team last run a documentation audit on your top 5 HCCs by submission volume? Mhm. Question number 3, the whistleblower question. The whistleblower in this case was a risk adjustment coding auditor. If you identified a pattern in your work that you believe constituted fraudulent billing, do you know what your first steps would be? Do you know who your internal compliance officer is? Do you know how to report externally? These are not hypothetical questions, they are professional readiness questions. Question number 4, the scale question. The government pays $530 billion a year to Medicare Advantage organizations. Does understanding the scale of that investment change how you think about the significance of your daily coding work? I want to hear how you think about the weight of what it is that you do and your importance. Question number 5, your one action after everything we've talked about this morning. What is the one thing you are going to do differently in your professional practice? If anything, you might say, you know what, I got this all in the bag. I'm good. It could be a policy review, an audit you're going to propose, a conversation with your compliance officer, a credential you're going to look into, whatever it is. I want you to commit to it out loud. Put it in the comments, make it real. All right. Now, I want to give you the good news because I'm always going to find the opportunity in the moment to give some good news. And there is a real opportunity here. Every enforcement action of this magnitude sends a signal to the industry. Okay. Yes, ma'am. There's no internal compliance department. I'll let y'all read the rest. All right. So every enforcement action sends a signal to the industry. We don't have to say nothing. This is telling our story, and unfortunately, we have things like this that now brings what we do to the forefront and the limelight, and enhances and augments the impact that we have. And this signal is one that this particular one also sends is we need professionals, need professionals who understand compliance, documentation integrity, and risk adjustment at a deep level. Organizations cannot afford to learn these lessons at $117 million a pop. And that's where you come in. Again, I have the 3 pivots for you. Some of them we've heard before, some of them maybe not. But these are deliberate career moves that positions you as exactly the kind of professional the industry needs right now. So let's go through them. Again, from code capture to compliance specialization. The first pivot is moving from being a coder who captures codes to being a professional who owns the compliance framework around how those codes are used. Compliance-focused coders understand the False Claims Act. They understand OIG guidance. They understand what a deletion obligation looks like and how to enforce it. They are not just coding, they are protecting their organization and themselves and their credentials. Your 3 steps to start this pivot. 1, pursue a credential, CHC credential through the Health Care Compliance Association or HCCA, the CPMA, Certified Professional Medical Auditor. That's through the AAPC. 2, read the OIG's Medicare Advantage industry-specific compliance program guidance. That just came out. That's new. We covered it in a prior episode, and it is foundational. 3, volunteer for internal audit functions at your organization. Be visible in the compliance space. The second pivot is moving into the intersection of clinical coding knowledge and data analytics. So going from an encounter level coding to risk adjustment analytics. The Aetna case is fundamentally a data story. Someone needed to be able to look at a population level submission, identify the morbid obesity codes, pull the corresponding BMI data, and recognize that the pattern didn't hold. That's not a skill every coder has, but it is a skill you can build. Tell him, Mr. Jesse. Tell him. Tell him.
And you know, it's so funny you should mention data because companies as big as that, they have internal data analysts too.
Mhm.
And it would be great if an analyst could look at the data and be like, just look at the codes and like, no, that's not right.
Mhm. Mhm. So here
But
you're. Oh, go ahead. I'm sorry.
no, good. But you know, they choose the people just got to stop being the coders need to stop being pigeonholed and realize there's a whole lot you can do in this industry.
Absolutely. Take them skills and max out. Be seen, be loud. Show them what you're working with.
That's right. And get paid.
And get paid for. Absolutely. Okay. So here's some steps. 1, you can earn the CRC, the Certified Risk Adjustment Coder credential through AAPC. If you already have it, when did you last review your continuing education against current enforcement priorities? 2, Build foundational data literacy, Excel pivot tables, basic SQL queries, report interpretation. 1 hour a week compounds into serious skill. We talked about that. We talked about that just last week at the meeting after meeting. YouTube University, y'all better check it out. LinkedIn, I don't know, I can't remember what their school is called, where you can get information from
LinkedIn
LinkedIn
Learning.
Learning. It was coming. All of the things, all of the places. There are places and opportunities, and a lot of it is free to low cost. Invest in you. I know that bag look good over there, but invest in you. All right. 3, study the RADV audit methodology. Again, RADV stands for the Risk Adjustment Data Validation. And this is CMS's process for verifying that submitted codes are supported by medical record documentation. Understanding RADV positions you as a resource when audit season comes knocking. And baby, that's all they were talking about at this at the annual meeting. Are y'all seeing a lot more ask and enforcement and audits coming through the door? It's audit season. They hitting, they coming. Be prepared, be ready. The third pivot is from coder to CDI specialist or HI educator. This one takes us upstream to where the documentation problem begins. The morbid obesity allegation in this case traces directly back to a documentation gap. The BMI didn't support the diagnosis. That gap between what was documented and what was coded is exactly what clinical documentation integrity specialists are trained to close. As AI-assisted coding tools take over routine code assignment, the professionals who understand data quality, who can query physicians compliantly, who can educate clinical teams on specificity requirements, those professionals will hold the highest value roles in the health information ecosystem. And I want that to be you. So your 3 steps. 1, pursue the CDIP, through AHIMA. That's the Certified Documentation Improvement Practitioner, or the CCDS through ACDIS, the Certified Clinical Documentation Specialist. 2, learn AHIMA's compliant query guidelines. Physician query is a skill, and it is a skill that protects patients and organizations simultaneously. And 3, position yourself as an educator. Offer to lead a provider education session. Create a 1-page tip sheet on documentation specificity for your top HCCs. This is where your AI skills come into play. Let it help you. Every time you teach someone else, you deepen your own expertise and build your professional profile. Now, I want to pause here and acknowledge something. And maybe you are listening to these 3 pivots and feeling a little overwhelmed. Maybe you are thinking, I just want to code. I came here just to code. I like coding. I did not sign up to become a compliance officer or a data analyst or a CDI specialist. And that is a completely valid feeling. You do not have to choose a full career pivot to benefit from this information in this episode. Even if all you do is deepen your understanding of why documentation accuracy matters in a risk adjustment context, even if you just go back to your desk on Monday and look at morbid obesity codes with fresh eyes, that is growth. That is professionalism. And that is exactly what the Saturday morning tea is for, to at least get you to look at things with a different lens, with a different pair of eyes. Yes? But for those of you who do feel called to level up, level up, level up, level up, level up, who feel the pull towards something bigger, towards a role where your knowledge shapes policy, trains teams, or builds compliance programs, I want you to hear me clearly. You have everything you need to start. You have the clinical foundation, you have the professional community, and now you have the map. The only thing left is the first step. So take it. Yes. So the machine can help find codes, but it takes a trained, principled, knowledgeable professional to ensure the data is right. The Aetna case did not happen because of a technology failure. It happened because of a process and integrity failure. And integrity is something a machine cannot replicate. That is your competitive advantage. Now go use it. All right. So we've covered a lot of ground today. And I'm so glad you spent your Saturday morning here with us. Let me close with the things I need you to do because information without action is just entertainment. And you did not come here for that, even though we do try to entertain every now and again. So, number one, subscribe and share this episode. If something you heard this morning is going to change how you think about your work or how someone you know thinks about theirs, then share the video. Tag a coder, tag a CDI specialist, tag a compliance officer. The whole community benefits when all understands the stakes. And that is something that we, again, all can benefit from. Next, I want you to think about, see, I'm trying to do too many things at one time. I want you to think about and come join us on Patreon. The PRN Hot Tea Sippers and the Elite members, your exclusive resources for this particular episode are ready and will be dropped momentarily. Hot Tea Sippers, your quick reference card for risk adjustment red flags is coming with documentation must-haves for all the high-weight HCCs we've talked about today. For our elite members, your live Q&A facilitator guide and your self-assessment workbook, Am I Audit Ready, are on its way to your inbox. That workbook alone could change the trajectory of your career. So if you're not part of the PRN Tea Sippers, come get it. Come on over here. Number three, do one thing from today's episode this week. Review your organization's charts. Yes, just take a look at them. Also, look and see if there's a chart review deletion policy. Look up one of the 3 credentials we talked about. Pull 3 records with morbid obesity codes and check the BMI alignment yourself. One step this week, not someday, but this week. I say it every episode, multiple times, and I mean it every single time. It can all be so simple. Code what's supported and withdraw what isn't. Ask the question when something doesn't align. Protect your credential. Know your rights. Build a career that could withstand a $117 million spotlight. You are professionals, you are essential, and this community has your back. Mr. Jesse, do you have any closing thoughts?
It was a great show.
Yes. And I love that you're here, even though you don't be acting like I need you to act, but you have this skill. You have this experience. You've seen this on all the different sides. So again, another benefit of being part of the Tea Sippers is the meeting after the meeting where you can query and you can ask questions. You got a whole expert or two here on on the compliance end, but also on the risk adjustment end. You can ask the questions that may be burning that you didn't want to necessarily ask on the show. You have the floor. Tap into what you got. All righty. Well, thank you again for joining us for another cup of tea and coding insights with the Saturday morning tea. Remember, keep coding with confidence, keep learning with purpose, and keep shining your light. Remember, we won't be here for another 2 Saturdays, but I'll put some stuff out there to keep you entertained and educated. This is Clarice Warner, the girl with the pearls, reminding you that when we lead with knowledge and integrity, we can navigate any challenge, even $117.7 million challenges. Woo, child. That whistleblower board, where is she? Ma'am, would you please come forward? I'm even looking like, where is she? Where can she be? Do I need to come to Philadelphia? Is she still there? Has she moved?
She's in the Maldives, relaxing.
And feeling good.
Mm-hmm.
That check cleared and cashed, and baby, I'm out.
Because look, the government does electronic fund transfer. So
absolutely.
She was
It's
at the
good.
airport when it hit.
Like, and 5, 4, 3,
Mm.
2, 1. Love it. All right, y'all. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a good weekend, and we'll see you in a little bit. All righty.
Bye.
Bye bye.